The laryngeal mask airway, commonly referred to as the LMA, is a supraglottic airway device. The main advantage of the LMA is that it does not require laryngeal visualization for the LMA's adequate placement. The LMA consists of tubing along with a 14mm connector which is attached to the epileptical inflatable cuff, positioned at a 30-degree angle. With respect to the posterior aspect of the tube, this is marked with a longitudinal black line, which should rest in the midline against the patient's upper lip when positioned properly. The LMA comes in a variety of sizes, 1 to 5, to accommodate patients from neonates to large adults. However, in the QAS, Advanced Care Paramedic Level 2 can only administer sizes from 3 to 5. And we've got 3 here, with the green packaging, 4 yellow, 5 blue. Now, as we mentioned before, it comes from sizes 1 to 5. Size 1 is for patients of weight up to 5 kilograms, and that's for infants. Size 2 for patients weight from 10 to 20 kilograms, that's a small child. Size 3 for weights 30 to 50 kilograms, and that's the adolescent or the small adult. Size 4, 50 to 70 kilograms, that's the average size adult. And size 5 from patients weight from 70 to 100 kilograms, and that's the large adult. With respect to the triple airway maneuver, it is used to maintain a patent upper airway and combines the head tilt, jaw thrust, and mouth opening. The indications are for patients unable to maintain an airway patency, contraindications nil in this setting, and precautions, potential C-spine injury. As stated earlier, the triple airway maneuver includes the head tilt, jaw thrust, and mouth open. Now we place a folded towel underneath the patient's occiput to ensure that the patient's airway axis is aligned. The head tilt. 2 hands are used to tilt the head in order to open up the airway. The jaw thrust. The jaw thrust moves the tongue anteriorly with the jaw. This further minimizes the potential for obstruction. Lifting from underneath the angle of the jaw on both sides of the head causes the jaw to thrust up and be forward. This position is usually maintained with assistance from an oral airway adjunct. The mouth open. The tips of both thumbs are used to open the mouth to visualize the oropharynx and to ensure the airway is clear, and also to check the patient's breathing. Please note that patients with potential spinal injuries, the triple airway maneuver is modified to include only the jaw thrust and the mouth open components. Now, before we demonstrate the insertion of the LMA and effective ventilation, let's talk about the LMA's indications. Actual loss of airway patency and/or airway protection. The LMA insertion is limited to 2 attempts per officer. Indications for the LMA, nil in this setting. Precautions and/or complications, failure to provide adequate airway or ventilation. It can precipitate vomiting and aspiration in a patient with intact airway reflexes. The insertion of the LMA can cause airway trauma. It can also cause maxillofacial trauma. It can also create patient intolerance when inserting the LMA, and also can precipitate laryngospasm on insertion and removal of the LMA. Now let's demonstrate the insertion and effective ventilation of an LMA. Now we have everything ready on a clean bluey to keep things clean. In case we need to, of emergency, we have a laryngoscope, suction and shears, and in preparation for the insertion of the LMA with all of our equipment here, size 4 LMA, which requires 30 ml of air from the manufacturer, 50 ml syringe, bite block, tape, bag valve mask, lubricant. Now, to ensure that in preparation of insertion of the LMA, we have to ensure the cuff is patent. So to do that, we take air out of the cuff and insert air in to ensure there's no leaks. Now we inflate the LMA with 50% of the recommended volume. It's a size 4. The manufacturer recommends 30 mils, so half of 30 is 15 mils. So we take air out, make sure we insert 15 to make sure the LMA keeps its shape. There we go. Now we apply water-based lubricant to the top of the LMA. Now we place the patient's head in the appropriate position to align the oral, the pharyngeal and the laryngeal axes. Or if the patient has suspected C-spine, we put in place manual inline stabilization. Now, in infants, this means slight elevation of the shoulders, and that's with a pillow or folded towels. In the small child, slight extension to the head. And in the large child, older child, or adult, as we've shown before, it's the extension of the head by placing some folded towels, or a couple of folded towels underneath the support of the head to keep the axes in line. With the distal opening of the LMA facing anteriorly, we insert the tip of the LMA into the patient's mouth. We advance the mask tip over the hard and soft palate and continue to advance the mask as far as possible into the laryngopharynx until resistance is met. We ensure that the black line of the tubing is in line with the patient's upper lip. Then we inflate the cuff with the remaining volume of air as recommended by the manufacturer. So it's 30 in all, already inserted 15, so another 15 mils to make 30 in total. And we see the tube rise. Now we'll confirm the placement of the LMA by touching the BVM, bag valve mask. And we should see misting of the tube as we do. We'll also take the chest to hear equal clear entry and rise and fall of the chest. And with the end-tidal, we make sure it's detecting and that there's a correct waveform. Now we're satisfied that it's in place with the checks. Insert the bite block. Once the bite block is in place, we secure the LMA with tape. And it's important when we secure the LMA with tape, we tie it in a bow. So in case anything happens, if there's an emergency, we need to take it off in a hurry, we can easily do by just pulling in the bow and the tape becomes undone. And that's the correct way to insert an LMA and to ensure effective ventilation of the LMA. Now let's discuss problematic patients and negatives with respect to the LMA. Negatives. An LMA does not fully protect the airway from aspiration. The LMA does not isolate the respiratory tract from the gastrointestinal tract. Therefore, regurgitation of contents from the stomach may enter the trachea. Other negatives include laryngospasm, suboptimal ventilation, bronchospasm, aspiration, desaturation, hypertension, and the conversion to intubation with ETT. These risks, as mentioned by Cheon in the references at the end of the video, and his peers, also discuss the fact that these risks increase twofold with patients with a BMI in excess of 30 or in patients older than the age of 46. Now on to problematic patients. Firstly, with respect to the problematic patients or the difficult airway, the establishment of an airway and the provision of oxygen and ventilation must be weighed against the risk of aspiration. As mentioned earlier, patients older than 46 or with a BMI in excess of 30 double the risk of adverse outcomes occurring. In the scenario of the hypoxic or anoxic patient, the provision of oxygen definitively outweighs the risk of aspiration of stomach contents as an adverse outcome. With respect to patients with difficult or abnormal airways, Smith and White have discussed that in the difficult airway, the insertion of the LMA is usually very straightforward. Furthermore, Langenstein study in a group of patients with known abnormal airways and he found that the LMA insertion was successful in 29 out of the 30 cases. An LMA typically causes less gastric insufflation than big bag valve mask ventilation alone. Finally, I'll discuss some troubleshooting strategies. In the rare occurrence that the LMA has been placed using an incorrect technique, it may be difficult to pass the LMA beyond the tongue, thereby causing the LMA to not pass smoothly into the hypopharynx. Additionally, incorrect technique of insertion leads to leaks in the LMA after the cuff has been inflated. Instances of stridor, laryngospasm, and complete airway obstruction, and even folding of the epiglottis have been documented. These all can usually be corrected by repositioning of the patient's head, readjusting the LMA position, or just adjusting the air in the cuff. In the worst case scenario, when in doubt, the reinsertion of the LMA from the beginning is always advisable. Thank you for watching, and hope you have found this presentation useful.